Good morning and welcome to UNC's twice weekly media briefing. I'm Phil Bridges in communications with UNC Health. Today's briefing will focus on the medical aspects of the COVID-19 pandemic with two of UNC Health's leading infection prevention and infectious diseases experts. And just as a note, we'll have separate audio for radio and video files for television and others that are interested later today. We'll post the video on our YouTube channel, and then you can email us and we will email you the audio file. And now I will turn it over to UNC Health's Alan Wolf, who will introduce our disease experts today. Alan?
Thanks, Phil. I'd like to say one of the reasons we're incredibly fortunate in North Carolina is that we do have some of the world's leading experts in epidemiology and infectious diseases. Dr. David Weber is Medical Director of Infection Prevention at UNC Hospitals. Dr. Emily Sickbert-Bennett is Director of Infection Prevention at UNC Hospitals. They will be able to answer questions about coronavirus, protecting patients and healthcare workers, aspects of the disease, efforts to flatten the curve, other questions that media have. Thank you for joining us both. Dr. Weber, would you like to make a few opening remarks?
Yes, thank you very much. I first want to say I've been here at the University of North Carolina for 35 years, where I serve currently as a professor of medicine, pediatrics, and epidemiology at the schools of medicine and public health. I also serve as the medical director of our Department of Infection Prevention and an associate chief medical officer for the UNC Medical Center. I'm happy and I look forward to answering any of your questions on COVID-19, including the new data on transmission, patient management, and UNC Medical Center's response to the pandemic, and how we keep our patients, visitors, and our staff safe.
Dr. Sickbert-Bennett.
Good morning. My name is Emily Sickbert-Bennett. I'm the Director of Infection Prevention, and I'm an Associate Professor of Epidemiology and Medicine Infectious Diseases. I've worked here in infection prevention for 16 years, and I have public health graduate degrees in environmental microbiology and infectious disease epidemiology. My professional interests are in the fields of hand hygiene, infectious disease surveillance, and infection prevention in the healthcare setting. Since the start of the COVID-19 pandemic, I've collaborated with my colleagues across the healthcare system to monitor the surveillance data, develop screening protocols for patients, visitors, and staff, implement universal masking practices, recommend PPE protocols, and assess exposure risks for staff and patients.
Great, thank you on that. And we'll begin taking questions as soon as anyone has them. So if anyone in the media has an immediate question, please just jump right in as we've done the entire time. It's worked pretty well. So any questions from the media, straight up?
Yes, thank you. I'm Lynn Bonner from the News and Observer. The WHO says that having coronavirus antibodies doesn't prevent a second infection. I'm wondering if that means what the broader implications are for the ability of people to be reinfected. And what does that mean for various reopening strategies that allow people who have had COVID-19 to resume their normal activities?
So I'll go ahead and answer that question. There are several aspects to it. First of all, in terms of antibody testing, of course, we'd hoped if someone demonstrated on an antibody test that they had positive antibodies, we would had hoped they would be immune for a period of several months to potentially a year. This would allow them to return to a work or a place such as a hospital with limited risk for infection. As you know, there have been a number of news reports of people developing symptoms with positive antibodies and after a period of being asymptomatic. First of all, it's not clear, and there aren't scientific papers out on this, it's mostly just brief news reports or discussions with scientists. So it isn't clear whether they're recrudescing their infection, meaning they still have a prolonged period of virus, they become asymptomatic and now they're shedding again with some symptoms, or that they truly had a prolonged period of asymptomatic time in between, were not infectious, and now they've been reinfected. And I have not seen good data that separates the two. Unfortunately, as you have already discussed, it means our planning for the future makes it much more difficult, because even now if we do an antibody test and people are antibody positive, we won't be able to assure them or their workplaces that they could not be reinfected. We still don't know how common this is, whether it's 2 or 3% or substantially higher. But it means that our current control strategies of screening people for symptoms, wide availability of testing, physical distancing to the extent possible, use of personal protective equipment and masks will need to continue at least until we see elimination of widespread community transmission. Since I think that we will see subsequent waves of COVID, we also will need to develop a surveillance strategy for when to turn back on those preventive methods in the future.
Additional questions from the media?
Hi, this is Sarah Vasca from NC Health News. I had spoken with some nurse practitioners and some providers, primary care providers last week, who mentioned that they've been surprised that a lot of the tests that they're running for, not for antibodies, but for the COVID virus, they're coming back negative, and they're folks that they feel have COVID. Can you talk at all about kind of what the research is showing, or what kind of anecdotally you're noticing about either false negatives or false positives, and basically how much faith people should be giving to these tests?
Well, I'll start off, and Dr. Sickbert-Bennett may want to make some comments after I'm done. So we believe the test done at UNC, the test done at the State Health Lab, Duke, and our other colleagues is both highly sensitive and highly specific. We're actually running 3 different test platforms, and we have excellent agreement. So if one test on one platform is positive, all of them are, or none of them are. And this is for symptomatic patients. So we think, in general, these are excellent tests, high sensitivity, meaning if the patient has disease, we know it. If the patient doesn't have disease, then that's reliable as well. Now, we are using a nasopharyngeal swab, which is a small cotton-like Q-tip that goes all the way to the back of the pharynx through the nose. And people who do not do this properly, that could lead to a false negative, meaning this is not like looking for methicillin-resistant staph in the nose, just the anterior nose. So you do have to get an adequate sample at the back of the nose. The other thing is we do know that these tests in the nose, the upper airways stay positive for 1 to 3 weeks. And we have seen here at UNC, and it is described in the literature, people have come in and presented later in their course of illness with pneumonia and more severe lower respiratory disease. Those people may have a negative upper airway test, but if you test the lower airways, and we do have a validated test for that, such as an aspirate, if they have a tracheal aspirate, or if we do a bronchoscopy, those samples may be positive as well. Now, of course, for asymptomatic patients, that's a little more difficult. First of all, the period of incubation from exposure to disease can be up to 2 weeks. A test negative today on Monday doesn't mean that somebody in the incubation period won't be positive tomorrow. So we need to keep that in mind, that a negative test in an asymptomatic patient doesn't exclude incubating disease. And since we don't yet have a gold standard test there, we don't actually know the sensitivity and specificity of measuring, finding COVID in someone who has no symptoms at all. So we'll have to wait on combining those testing with periodic antibody testing to see if we're missing those people. But they're not really false negatives, because in fact, our testing doesn't pick up any disease in the asymptomatic period before you develop symptoms necessarily. So for instance, mumps, measles, rubella, varicella, we can't test you now and tell you if you're in the incubation period and exclude the possibility you would develop disease.
Dr. Sickbert-Bennett, any thoughts in that area?
Yeah, I would just add that, throughout the season, we continue to do surveillance for other respiratory viral illnesses. And when we first started seeing COVID in our community about a month ago, we were also still seeing, relatively high levels of some influenza, respiratory syncytial virus, and other viruses as well. And this is really the value of having robust surveillance systems that can tell us exactly what's circulating at the time, so that we can get a bigger picture of really what the health burden is on the community besides just the disease in question.
Additional questions from the media, please just jump right in.
Ken Smith of WRAL News.
Hey, Ken, go ahead.
With that in mind, we just mentioned the burden on the health system. Looking ahead to the fall, even in December, when influenza returns, we could have influenza and COVID on our hands. How challenging is that for the medical community moving forward?
So it certainly will be challenging, and we do see, even pre-COVID era, we do see people who had more than one viral pathogen at a time, so influenza and RSV, or human metapneumovirus and parainfluenza. So, you know, a reasonable percentage of people will have more than one virus. We expect that currently, you know, we have our respiratory pathogen panels that pick up things like non-epidemic coronaviruses and RSV and influenza. And now we need to do a separate COVID test. I would expect by the fall season, these panels that include multiple different viruses, and in some cases bacteria, will also include COVID. So we won't be doing two tests. We'll be doing a single test that would detect COVID plus additional viruses at the same time, which will make our surveillance efforts much easier. I do expect that we will have another peak based on 1919 influenza pandemic and the widespread nature of this disease, including the fact that we're seeing cases in places like Australia and New Zealand. We were seeing them in January, February, when they are in the middle of their summer season. So not where we usually see these viruses. And we'll need to develop, and there already are surveillance systems run by the State Health Department in North Carolina, as well as the CDC on influenza surveillance. We'll need to develop a similar surveillance system that will allow us to detect early transmission in the community of COVID. I'm sure that will be done. And then based on transmission of COVID, there will be a series of escalating preventive methods that are used in workplaces and in hospitals, much like we already do for influenza.
Great. Please, additional media questions? Dr. Sickbert-Bennett, while we're waiting for possibly some more media questions, you know, we hear so often that people test positive for coronavirus, some people, and maybe even a good number, with mild or no symptoms at all, asymptomatic. How is it that the same virus could gravely injure a significant number of people, but others seem completely unfazed?
So this is not all that uncommon with respiratory viruses. Something like 40% of patients with influenza have mild or moderate disease or are asymptomatic, much like this. And we need to separate here asymptomatic, truly people who will never develop symptoms, from presymptomatic. And that actually seems to be, particularly in the studies in the nursing homes, fairly common, where they test somebody at the time that they have no symptoms, and then 2, 3, 4 days they have symptoms. This virus is a little unusual in that, at least when you look at the amount of virus people have, the time the symptoms start is when their amount of virus has peaked, which suggests clearly that in the day or two before that, that they will have a virus. And we do believe that pre-symptomatic people can be infectious. We don't know how many people they would infect. Asymptomatic is a little harder. Of course, by definition, you're not coughing and sneezing. So there are some case reports that suggest that they can be infectious, but we really don't know how likely that is and what the frequency of that is. And until we can get the serologic tests and test a large number of people, we don't know how common it is to be totally asymptomatic. But the data would suggest somewhere between 10 and 30% of people who have COVID are truly asymptomatic, and that 80% of people who have COVID or more are very mildly symptomatic. And we do know that the things that make you more ill are particularly age. That is, as you get older, particularly over 65, and as you get older than 80, you're much more likely to have severe disease and pass away. Whereas in children, it seems to be mostly either asymptomatic or very mild disease. And then comorbidities, things like underlying kidney disease, heart disease, immune suppression from cancer, also make it more likely that you'll have severe disease.
Great.
And I would just add, from a surveillance perspective and pulling from the example of influenza, our Dr. Weber mentioned how robust we have always had for, in terms of our surveillance system for influenza. If we took a lesson from influenza and thought about all the different ways we could really categorize disease for COVID, this is going to be really important for us to understand when we see the second wave, how many people are severely ill. Most of the data that we're seeing right now is on hospitalizations and ICU stays and ventilator use. But as you appropriately say, there are a number of people who are sick from this disease as well, who may be at home. And with influenza, we have so many different data sources that we're looking at to really understand and get estimates of the burden of disease beyond just what we're seeing in the hospital. We have syndromic data on patients that are coming in through the emergency department. We're able to track Twitter feeds and Google searches and WebMD searches and all types of non-traditional data sources. And I think in order to really get a better picture of the epidemiologic impact of COVID, and particularly as we approach another wave into respiratory virus season and influenza season, we are going to have to make some investments in those surveillance systems so that we can really understand what's happening with the disease.
Questions from the media, please.
Yes, I've got another question. Since people who are asymptomatic or presymptomatic are shedding virus, I'm wondering how effective these screening procedures are where temperatures are taken. I mean, isn't it likely that there are a lot of people who are shedding virus who are slipping through these gateways where people are taking temperatures to see if people are sick?
Well, let me start off by saying even when people have symptoms at the time they have symptoms, as many as 40% will not have fever at a very low definition, meaning 100 degrees, which is lower than we usually think of as indicating most infectious diseases. And you're right, and we don't really have a true incidence of people who may be infectious and be pre-symptomatic or asymptomatic. By definition, no symptom screening would pick up those individuals, although I will say we now have a wider range of symptoms we screen for. We started off with fever and lower respiratory symptoms, meaning cough and shortness of breath. We expanded that to fever or lower respiratory symptoms. Then we added in upper respiratory symptoms such as sneezing and sore throat. And we've continued, then we've added on things like loss of sense of smell and taste, extreme fatigue, nausea and vomiting, shaking, chills, headache, and others. So we've expanded our symptom screening, which obviously picks up more people now that we have a better understanding of the disease. But you are correct that none of those symptom screens would pick up a truly asymptomatic person. And this is why many centers, as we think about how to reopen, both here at UNC and Duke and many other places in the United States, are developing or have developed protocols for screening asymptomatic patients with a priority of people who are going into congregate settings, things like obstetrics and labor and deliveries, where they might be visiting the nursery or coming into a psychiatric facility or rehabilitation hospital, or a nursing home where they would be in a congregate setting, about screening people who are asymptomatic. And many people are moving on then to pre-procedures in order to protect the patients. Certainly an elective procedure like a hip replacement that could be postponed. You really don't want somebody to come down with COVID in the next day or two there. So we're beginning to screen those individuals. Now, leaving that aside, there are other ways we can protect our patients and our healthcare system, and are doing it by assuming everybody might have COVID. And I'm going to let Dr. Sickbert-Bennett talk about all of those protective mechanisms that we are now following, with the assumption that everybody might have COVID with or without symptoms.
Yes, so some of the examples that we've implemented here at UNC hospitals, besides the screening, as Dr. Weber mentioned, that we're doing, which is more comprehensive than just taking temperature, but looking at a whole host of symptoms. that have been associated with COVID disease. We do that daily for all of our staff. Any visitors who are allowed to come to the hospital also have visitor screening for symptoms. Our patients are screened, as we discussed. But then the other important infection prevention measure is the universal masking that we're doing, and that also is another guardrail for prevention when we have asymptomatic carriers.
And I would add to what Dr. Sickbert said, and when she mentioned universal masking, we mean universal masking of all healthcare providers while they're in our medical facilities, and all patients when they're in a clinic or a medical facility. So both groups are masked, which dramatically decreases any possible risk of transmission, even if one of our patients was asymptomatic and infected.
Questions from the media, please just jump right in.
Hi there, Sarah Vaska again with NC Health News. Obviously, some of our neighboring states are starting to open up their social distancing a little bit. What concerns do you all have, and what are you expecting, fearing we might see in North Carolina as an effect of this?
Dr. Sickbert-Bennett, you want to start on that one?
Sure. So we certainly worry about loosening of some of these control measures as we are tracking the outbreak very carefully here. We in North Carolina are still seeing increased numbers of cases, and we look for, in any disease outbreak, a decrease in those numbers of cases before we feel more comfortable allowing people to enter back into congregate settings. Some of our outbreaks, as you know, currently in North Carolina are in settings where people are close together, and by nature of the nursing homes and the prisons and things like that. So it is important that any time we can make a choice to stay more distant, that we're able to do that really until we start to see a decrease in the number of new cases every day.
Questions from the media?
Ken Smith of WRAL, one more time. Piggybacking off that question, how concerned should North Carolina be with Tennessee, South Carolina, and Georgia reopening some businesses, and knowing how people travel from state to state?
So let me start with that, and then I'll let Dr. Sickbert-Bennett comment. So I think we should have some concerns. We do know from the outbreak of SARS that in Toronto, where they actually had a substantial decrease, almost to zero of their cases of SARS, but very rapidly then stopped physical distancing. By the way, we prefer the term physical distancing to social distancing. We want people to stay separate, but we want them to stay socially connected. They had a very large second wave immediately afterwards, and this is a natural experiment. To the extent that we have ongoing community transmission, we've already mentioned the importance of asymptomatic, presymptomatic individuals who therefore might not be home, that we have mixing of large numbers of those peoples without people wearing masks in particular, then we will see more cases. And as you point out, people can travel back and forth across borders. So if we do see increased cases in the surrounding states, that will have an impact on North Carolina. Given the incubation period, it's about an average of 7 days up to 2 weeks, and the multiplication effect, it's probably going to take somewhere between 2 to 4 weeks to know whether the stopping in the neighboring states of some of their physical distancing leads to increased cases, and what impact it has on North Carolina. So we won't be able to tell this in the next week and probably 2 weeks, but it'll take a longer period of time.
Dr. Sickbert-Bennett, any thoughts in that area?
Yeah, I would agree. I'd say this is really, again, another key factor for having really robust surveillance systems, not just within North Carolina, but across the United States, so that we're really tracking and measuring the number of new cases. And as we loosen some of our control measures little by little, we're able to see really what the impacts of those are, and we can quickly make data-based decisions on if it's time to implement a control strategy back again.
Questions from the media? One question I thought that folks might be interested in, many experts had said prior to this outbreak that, it was not a matter of if we would have a global pandemic, but when. And you hear that all the time. And now that we are experiencing one, should we expect these on a regular basis, or is this a once in a lifetime phenomenon?
So let me start off with that and say, agreed, it's a matter of if, not when. And this hopefully will be once in a lifetime large pandemic with a huge number of cases and deaths. And the model for this, of course, would be the 1819 flu pandemic, which killed hundreds of millions of people around the world. But certainly in the last 100 years, we've had many pandemics and outbreaks. Those have included new diseases like HIV with an ongoing pandemic that is still not controlled to this day. And while it never peaked quite the way COVID does, it's had a larger impact in terms of number of deaths. We've had SARS, we've had MERS, we've had Zika, we've had West Nile fever. So we see these emerging and re-emerging diseases with great frequency. We obviously need to develop surveillance systems. We need to substantially increase the ability of the federal government, our states, our counties, and academic centers to respond to future pandemics and epidemics. COVID came from bats, and we've seen two other bat coronaviruses explode into humans, SARS and MERS. We could see another one in 1 year, and we may be another 50 years before we see emergence. 2009, we had an influenza pandemic with a new strain of influenza. We were fortunate in that case that the virus, while reasonably infective, was really not particularly virulent. By that, I mean it didn't cause any larger numbers of deaths than standard influenza, but it could have. It could have more mimicked 1919 and what's happening now with COVID. So while I can't predict when we'll see the next large pandemic, I can predict we will see more pandemics.
Hi, considering the extent of community spread here, how many contact tracers does North Carolina need to do an adequate job?
It's a great question. Traditionally, each local health department is tasked for doing this for their county, and how many they would need is I don't know. I can tell you within the hospital where we are sort of a mini health department, and we're doing contact tracing for any positive patients and staff that we have. It is an effort of a 20-person infection prevention department with supplemented by an occupational health department that is even more robust than that. Probably another 10 to 15 people doing this effort as well. It's a time-consuming job. Each patient has to be carefully interviewed, and then the contacts have to be notified and given control measures. So it is definitely a time-consuming job, at least to do it the traditional route, which has been by phone interviews.
We only have about minute and a half left. Any final thoughts today from either of our guests?
No, I'll just make one statement. I think the cases seem to have plateaued with appropriate continued physical distancing and with mitigation strategies that Dr. Sickbert-Bennett has talked about, such as surveillance, increased testing, contact tracing, use of personal protective equipment. I think that we will be able to handle future waves much better and logically plan for how to reopen here in the United States. Everything is dependent in part upon increasing our personal protective equipment supplies, developing surveillance and having adequate testing.
And I would just say in closing that, you know, we have a lot of lessons learned from other infectious disease outbreaks and how we can do surveillance and contact tracing. But I think in order to really propel us to where we need to be for response mode, we do need to think differently outside of the box. Contact tracing, the way it's historically been done, as I just described, is very labor intensive and very slow, and the need for having technology to assist and for us to think of innovative ways to use data and use technology to help us do some of these control strategies is really key.
Great. Thank you very much both for being with us today. We greatly appreciate it. We are out of time now. Again, for the media, we'll have an audio file for radio if there's any folks that want that, or anyone else can get it as well. We can send you that. And then we'll upload the video to YouTube shortly here. And so that will be available before the afternoon. So that concludes the UNC Health Media Briefing for today. Thank you, and we'll see you next time.